Hello and welcome to another webinar on COVID-19 and mental health. Now, if you've been to these webinars before, you'll know that they are a joint effort between United for Global Mental Health, the Lancet Psychiatry, MHPSS.net and the Mental Health Innovation Network. And we've been very pleased throughout these webinars to have the support of our friends at WHO. Now, the subject of today's webinar is suicide prevention. This is a hugely important topic, also a very sensitive topic. And I think the importance is really reflected in the numbers that we're seeing joining us today. Indeed, the subject of suicide prevention was the theme of the first issue of the Lancet Psychiatry, as it's something which really touches on every aspect of mental health care. And it goes beyond that too. We know if we read newspapers, if we listen to the radio, if we watch TV programs, that often suicide figures are used in some way to diagnose the state of health of nations. Now, this can be a useful thing in terms of keeping a very, very important issue prominent in the discourse, but it can also have some disadvantages, and we'll be covering both aspects of that today. Now, if you're tweeting, please feel free to use the hashtag, which is COVID-19MH. And if you have any questions, you can email them to the address you'll have got with the registration. But without any further ado, I'm going to introduce our panel. I'm delighted to be joined by Murad Khan, who is the Professor of Psychiatry at the Aga Khan University in Pakistan, by Chris Caulkins, who's joining us over the audio link only. Now, Chris is the Executive Director and he's a suicidologist at the Minesota Center of Suicidology. And he's also the lead of the YASP, that's the International Association for Suicide Prevention Lived Experience Special Interest Group, and Chris is based, of course, in the US. We're joined from Edinburgh by Michael Eddlestone, who is Chair in Clinical Toxicology at the Centre for Cardiovascular Science at Edinburgh University in Scotland. And then from South Africa, we have Cassey, who is from the South African Depression and Anxiety Group. So if you've joined us before, again, you'll know the format. If you're unfamiliar, I'll just go through it briefly. I'm going to ask the panelists a couple of questions. Then what we're going to do is move through to any questions that you have, and then we'll have a final roundup. And I'll tell you a little bit about future topics which this webinar will be covering. But I'd like to start for now with Murad. Now, Murad, why is the illegality of suicide in some countries such a barrier to suicide prevention? How does it stop us finding and treating those who need mental health support?
Thank you, Niall. Unfortunately, while suicide has been decriminalized in the majority of the countries, there are about 40 to 45 countries in which it's still a criminalized activity. And these 40 to 45 countries also include quite a few of the Islamic countries in which suicide is condemned very, very strongly, more so than some of the other monotheistic religions. And as Islam goes a little further than condemning suicide. Now, the fact that it is criminalized in these countries stop people from seeking help, coming out, discussing about suicide, addressing some of the underlying issues that make people indulge in self-harm acts. It also affects the surveillance system, the collection of good data, which really should inform policy. So it's got a range of problems when an act is criminalized, as it is in many of these countries.
And I think this also affects the way that the general public think about suicide. For instance, one of the phrases which I know people in the suicide research field get quite sensitive about, and understandably so, is the phrase to commit suicide, because that implies that it is a criminal act, which it isn't in many countries, but as you say, it still is in some. And you know, even the very language that we use to talk about suicide is shaped by its history of illegality and its present state of illegality in some countries.
Absolutely, I agree with you. I think terminology is extremely important, and the word commit really kind of indicates that it is something wrong, it is a crime, which it isn't. The person or the individual who indulges in suicidal behavior is a person who's in the throes of a crisis, maybe under stress, maybe suffering from some mental disorder. His or her ability to make informed decision is severely compromised, and such a person really should not be punished, but should be looked at from a more compassionate view as someone who needs help, And so the whole approach to decriminalizing suicide really has to be from a public health and a human rights perspective, rather than from a legal perspective, whereas you punish the person. And in some ways, although in many countries, I think the law is based on its deterrence value. But if you look at the data and the research findings of many of countries over the last 50 years, it certainly has very little deterrent value now. And therefore, it's time for the countries that still criminalizes suicidal behavior to really look and to repeal these laws.
Okay, so what you've just told me is that there doesn't appear to be a value in deterrence, that illegality affects data collection, that it affects help seeking, that it affects treatment. With all of these things in mind, why is it that it is so hard for the law to change in some countries?
Well, I think different factors operate in different countries. Certainly, I can talk of my country, Pakistan. It is a country where religion plays a very important part in people's daily life, and because the law is on one of the tenets of Islam, that if you die by suicide, using the word commit by suicide, then you will be denied entry to heaven. And therefore, many people have really not thought through, and what they've done is taken what is mentioned in the Quran about taking your own life to people who make self-harm attempts and survive. And they have applied the same ruling, the religious ruling that is applied to suicide, that is for suicide. And again, it's for a deterrent value to self-harm, and they've applied there. And therefore, anyone who makes an attempt and survives can be punished under law by a prison term or a hefty financial fine. So one of the reasons why in Pakistan and many other Islamic countries they don't address that is because no one wants to touch it. It's a very sensitive topic, and therefore they stay away because of the backlash that may come from the religious lobby. That's one thing. The other thing is mental health in many countries has very low importance, and therefore it is not something that is discussed in the public domain a lot. And suicide and suicidal behavior being a very personal act is again something that is not discussed from a public health perspective, rather than as an individual act, and the person is responsible, and therefore we don't need to address that in a holistic manner. So these are some of the factors that kind of play a role. And like I said, different factors, local factors may be playing different roles in different countries.
Thank you, Murad. Now, you've set out very clearly there the challenges. We also, in this webinar, like to come to the solutions, and that's something which I'll return to with you later, if I may. But for now, I'd like to turn to Cassey. Now, Cassey, can you describe the work of SADAG, and can you tell me a little bit about the present moment, about the way that the COVID-19 pandemic has specifically affected the situation regarding suicide and self-harm in South Africa?
Thank you very much for having us and including us in this discussion. So SADAG, the core of what we do is we provide free telephone counselling through a call centre or helpline system. We have over 22 helplines that we run around the country, and we provide free telephone counselling, crisis intervention, and really just assistance to people who have no resources. Since the beginning of lockdown, for the first time in 26 years, we had to close our call centre and move everything remotely or online to assist people. And what we've noticed is that from the beginning of lockdown, or just before lockdown, we were getting about 600 calls per day. And since lockdown, our calls have dramatically increased. Our call volume at the moment is we're receiving over 1,400 calls every single day, and the number is growing each and every day from people who are really struggling, and the mental health impact has been huge for a lot of South Africans. And we've seen the really phase of how it's changed from the beginning of lockdown, which in South Africa happened in March, the end of March, to even now that we've been over 4 months in lockdown and different regulations, and the impact that it's had on people's lives has been immense. And the demand for our services has been growing each and every day. And, through this time, we've been spending a lot of time to really understand the impact, what some of the challenges are. We conducted a survey in April, just really trying to understand the mental health impact or challenges for a lot of South Africans. And from over 1,200 respondents, the main issue was anxiety and stress, financial stress, and then depression. We even further were involved in some research that was done in May that saw that 49% of South African employees, so people in the workplace, had symptoms for pre-PSD. So the impact and the psychological impact on people has been immense. And we're seeing reports on a daily basis of people who are not coping. Just today, there was another newspaper article with an 18-year-old adolescent who had taken his own life, just not being able to cope. First time with online schooling, it's his final exams, all the extra pressure. There's a lot of people in South Africa who are not coping. And I think what's also been significant for our country is that before COVID, we already had a huge strain on mental health services before. We didn't have enough doctors, not enough beds, not enough resources. And during COVID, and especially during lockdown, those lack of resources has becoming even more apparent and added extra strain to our already strained health system.
Yeah, there's one thing which I'd like to follow up in that, which is that I've already spoken about the importance of suicide prevention. And as I said, the numbers joining us today are indicative of that. But one of the things which has always struck me about suicide prevention is, despite it being hard to get a good evidence base for what works in terms of prevention, because the usual thing that we use in medicine, which is the randomized controlled trial, it kind of doesn't work when you come to suicide prevention. So is there a process in your organization by which you can investigate and evaluate what works? And if so, how does that operate?
And that's really important, especially in the work that we do. We're an NGO, we don't get funding from our local government. So for us, it's really important to make sure wherever we're putting our efforts and our energy, that is really evidence-based, true trials. And we use a lot of that data coming through our helpline, and where we understand the kinds of challenges that callers are bringing forward. So that first line, front line, kind of lived experience is really important to us. And we pick up all the different challenges of people accessing treatment, medication stockouts, and then we're able to tackle those. So we do a lot of our own in-house research using the calls and the caller data that we get. We run various online surveys, and while that's really helpful to give us insight, we're also very aware it's not necessarily nationally representative, especially for a large proportion of South Africans who don't have access to internet or grassroots level. So it's really important for us to continuously do research. And I think, even during COVID, we monitor our call volumes, the kinds of issues we're getting on a daily basis. So we're constantly looking at our own strategies. Is this working? What do we need to do? And I think one of the advantages of that, even during COVID, where traditionally we could go into schools and speak to youth about mental health and suicide prevention, we could go out into communities, we've really had to think of that very carefully and go everything virtual or online. So we've seen a huge uptake in people accessing resources during COVID online through various WhatsApp groups. We've also changed the way we run certain projects. We have over 200 support groups around the country. We're now actually turning them to all the online support groups because people are needing to connect. So yes, evidence-based research is incredibly important to us. We work very closely with our local universities to help us to develop that data and really study what we're seeing so that we can constantly make sure that the work that we're doing is making an impact and is making a difference.
Thanks, Cassey. Now, I'd like to take one point from that answer and turn to Chris now, which is the importance of lived experience. Now, Chris, I wonder if you could tell us about what the lived experience of people who have been suicidal, who have self-harmed, adds to the evidence base for suicide prevention.
Right, thank you. Yeah, I think we'd be hard pressed to find people that disagree that that perspective has been missing from research and influencing our efforts for a long time. So it gives a richness and empathy and an increased understanding. It's sort of like an ethnocentrism, if you will, but everybody looks at it from their own culture and perspective. But if you don't look at it through the lens of a person with lived experience who's felt the sting of suicidal ideation or that of having experienced the death of somebody they care about. And survivors like myself are passionate. We bring a lot of energy and not that other people don't, but it's a different level of understanding, I think.
We've seen a lot of destigmatization of mental health issues over the past 5-10 years. To my mind, that hasn't been completely an even process. Some issues are still, I think, quite stigmatized. And clearly, given what Murad was talking about, I wonder if suicidality is one of those things which still is very stigmatized in certain settings. Do you think that stigma is an issue in affecting the participation of people with lived experience in suicide prevention?
Is that's directed to me, Chris?
Yes, it is. Yes.
Yes. I definitely believe that it's difficult to disclose. People often call it coming out, like anything else that you wouldn't discuss. Even things like sexual orientation, things that are touchy. You know, if you want to shut down a conversation quick, if somebody asks me how my wife died, I say she died by suicide, and that's a showstopper, right? It's the no cake death. Nobody's coming over to bake you a cake or mow your lawn or do something for you, and that they just don't know what to say or do with it. Plus, there's this specter of when people like myself who've experienced also ideation that were somehow dangerous. When of course the research is clear that people who have a mental health issue are more likely to be the victim of a crime more than a perpetrator. And I think so I think it's difficult because of that. And I have suffered repercussions for disclosing myself. I am also a paramedic and respond to a lot of calls for suicidal ideation and attempts and sadly deaths. But disclosing it myself, we kind of eat our own. Like there's something wrong with you. Like I wouldn't, like somehow you're damaged. But I always tell people I'd rather have the paramedic in the ambulance, the pilot in the cockpit, or the surgeon in the surgical suite who's had ideation but been successfully treated any day than the person who's stuffing it, not getting care, that kind of thing. That's what scares me. You would want me in that kind of, I'm very empathetic, and I think I do a real good job of taking care of people because of that. Anyway, I don't want to go into a whole diatribe, but yeah, so the answer to your question is, yeah.
And of course, Chris, the individual level of care given to people who are experiencing suicidality is very important. We'll return to that in a moment. For now, I'm just going to go over to Michael, and we're going to talk about suicide as, of course, a public health issue. And, you know, looking back at the history of psychiatry, one of the very successful ways in which suicide is prevented is through public health measures. Now, you've worked on a specific public health measure, that is the control of pesticides, as the use of pesticides to self-poison is a common method in some parts of the world. So I wonder if you could tell us a bit more about that. Why is access to pesticides such an important factor in suicide prevention, and where in the world would this be important to think about? You're muted.
I'm no longer muted, I
Great.
believe.
We can hear you now. Go ahead.
Apologies. So If we go back to the 1950s, in the early 1950s, synthetic pesticides were really not commonly used in agriculture, and therefore pesticide suicides were really rare. Then the agricultural green revolution brought these pesticides into practically every, particularly Asian farmer's household, and they were really toxic compounds. A small sip, a mouthful was enough to kill. So suddenly, every act of self-poisoning, which is a common response to stressful situations, became high risk. People who had previously survived their act now died. As a result of the ready availability of these toxic pesticides in all these communities, the suicide rate shot up, particularly in rural Asia. It was not because more people wanted to die, but because suddenly the poisons available at those moments of crisis, what was lying around, when people weren't really thinking carefully about what they were doing, they're responding to the situation, suddenly those poisons were lethal. And unfortunately, self-poisoning doesn't really need much planning. Unlike other lethal means, such as hanging, where you have to find a rope and find a hook, here you simply grab what's close, and if that bottle's lethal, 3 seconds later, you've drunk a lethal amount and you're going to die. And there's no time to change your mind. So in the late 1980s, early 1900s, there were about 350,000 people were dying prematurely every year from pesticide poisoning. The number now is probably around 150,000. It's still a huge number. It represents about 15 to 20% of all suicides worldwide. Now, if we can stop pesticide suicides by preventing access to these highly hazardous pesticides, then the global suicide numbers will fall, perhaps even overnight, very rapidly, by around 15%. And the reason we know that is because we know that most people who survive drinking pesticides do not go on to try another method. The best evidence for that is from Sri Lanka, where bans of these just 8 pesticides in the 80s and 90s resulted in more than a 70% reduction in total suicides, because pesticide poisoning was so important for suicide in Sri Lanka at those times. But what is really interesting is the rates of self-poisoning of people taking poison to communicate stayed the same or even went up. At the same time, there was a 70% fall in deaths. So people were still harming themselves, but were no longer dying. They survived to get the support they needed from their family, their community, and their health services. And it's not just Sri Lanka. If we look in Bangladesh, South Korea, Jordan, China, and parts of India have all successfully reduced access and seen a marked fall in deaths. So I think controlling access to pesticides is really important for global suicide prevention. And fundamentally, it's the low-hanging fruit. It's the people who have low intention to die, who we can stop dying.
So if I understand you correctly, this sort of busts one of the big myths about suicide, which is, oh, if someone wants to end their life, they're going to find some way to do it. The evidence which you've quoted and the bulk of the evidence suggests that that is not the case, that in fact, if you control the method, if you control lethal methods, you do save lives and those lives stay saved. I'd like to just dig in a little bit more to when you talk about pesticide control, what exactly this means. Do you mean providing lockers so that people can't access pesticides? Do you mean controlling sales? Do you mean less lethal formulations? What mechanisms exactly are you talking about?
So I think about suicide prevention with pesticide suicides at 3 levels. You work with the patient and try and stop them dying after they've taken the pesticide. But that's really difficult because people are really sick. It's very hard for them to get to hospital in time when the hospitals aren't resourced. You can work with communities and trying to control how a community uses pesticides. Can you make sure they lock it away every night? But I don't put my clothes away every night. The likelihood of me taking my lethal pesticides and locking it away safely in a way that I can't access it when I'm drunk or upset, or anyone else in my family, is quite difficult. The most effective way is to simply make them safe. Make pesticides that when you drink them, you're safe. And I'll maybe come back later when there's more time to that particular point. But the idea that you can store a pesticide in a household safely, we've proven in the randomized controlled trial of 235,000 people in Sri Lanka over 5 or 6 years, that really that doesn't work. And I think one of the reasons for that is the people who self-harm don't actually think it's their problem. They're not saying 3 years down the line, someone in my household is going to self-harm, therefore I have to plan now. These things sometimes come out of the blue, perhaps, and it's hard to predict. And the people who probably should have locked the boxes maybe didn't see it as their problem.
So the message I'm getting overall is that there are some general principles in terms of suicide prevention, but they have to be refined for specific settings. So for instance, some of the principles which you're talking about in terms of pesticide use in some parts of the world, we could take them to other lethal means such as firearms, for instance, in parts of the world where firearms are sort of commonly sold and used. So I'd like to turn to Murad now and ask if there are any successful ways that you can highlight in particular that the governments have used to reduce national suicide rates.
Yes, the models that are successful are the ones that have a comprehensive national suicide prevention strategy. So that's very important. You can't just take one bit, address that, and expect the suicide rates to come down. So the first and the most important thing is a comprehensive policy strategy. Within that, you can have different elements, and restricting pesticides certainly can be one of them. But you have other things also which really need to be taken into account as well. For example, in many of the low and middle income countries, we don't have good surveillance systems. And the absence of the surveillance systems mean we don't have good data on which we can measure the impact and of any kind of intervention. So that is fundamental, and very, very few countries actually have that. So when we look at the examples of countries from the non-Western world, then Iran is really one of the countries that has a very good surveillance system. Unfortunately, Iran is not talked about for various reasons, but I had the opportunity to go and review the suicide prevention program a couple of years ago, and they have built an indigenous program in which the data is really uploaded within a month. And to have the data accessible for researchers, for policymakers, to bring about changes in suicide prevention activities is extremely important. And so Iran certainly is one of them. And there are many other countries that have developed national suicide prevention strategies, including Bhutan, including Namibia, Switzerland from the West, Republic of South Korea, and so on. So these are good examples where a suicide prevention strategy has been developed. They may have targets which concentrates resources, which concentrates people to work towards the targets, and an overall general improvement in the mental health care. So the fundamental thing, I think, is a comprehensive national prevention strategy. And within that, I think leadership is extremely important. When you have that, then you have a strong advocate who can raise the voice, and you get the government's commitment to follow that.
Thanks. And I'd like to follow up one other strand as well, which is we were talking earlier about the legal situation, and how despite the evidence, there just seems to be this reluctance on the part of governments to alter that. Are there any successful strategies which you could recommend to pressurize governments, to help governments to change the law and prevent suicide being illegal, and then in turn help with prevention and help with better data collection?
So again, there's a range of approaches that are used and can be used. I think the first and the most important thing is destigmatization. That is very important, to bring a subject into the public domain, to discuss it, to debate it, raise awareness, and gradually decrease the stigma. That's very important. Through that, advocacy is very important, and to do that, you really have to engage with all stakeholders, not just public health professionals and policymakers, but people with lived experience, people in education, in the justice system, in the law enforcement agencies. You really have to develop a groundswell through which the subject, the topic is highlighted, and through that you can then pressurize the government to bring about the changes that are required. Now, the last country, to my knowledge, that has been successful in decriminalizing suicide has been India. So in India, a few years ago, it was decriminalized. Someone challenged that. It was again criminalized, and now I think about 2 years ago, it has finally been decriminalized. And there's a lot that we can learn from countries like India.
Thank you. So in brief, the message I'm getting from you is that suicide prevention is about far more than just what we call the mental health world. it's something which we really need to involve stakeholders at every level with. And with that in mind, I'd like to again refocus on the situation at the moment with the COVID-19 pandemic and turn back to Cassey. Is there any specific guidance, any specific measures for addressing the problem of self-harm and suicide during the pandemic, and what do you think needs to be done going forward?
And that's such a good question. And I think even just in South Africa, what we've seen in a lot of our kind of government communication during COVID was not to go to hospitals, not to go out in public. And that message that was then portrayed into the community was not to go to hospitals to get your treatment or your medication. And we actually saw that in the last few months, people are relapsing, they're not getting treatment, they're too scared to get treatment. And one of the things that we're thinking now that is really important is to create awareness on how to access help during COVID, how to go safely to hospitals, how to continue seeing your mental health professional. And that's really important to curb the increase in suicide, especially amongst South Africans where we don't have enough resources. I think one of the things that we also had to look at from the beginning was instead of directing within our hospitals where we don't have enough hospitals and a lot of our main hospitals were converted into COVID hospitals, is to make sure that they didn't convert beds allocated for the psychiatric ward or mental health to COVID patients, to keep those wards still running so they're still able to address and deal and treat patients with mental health issues. One of the problems we have in South Africa before COVID is we didn't have enough beds for adolescents. And we know that in South Africa, our most at-risk age group is our young between the ages of 14 and 17 years old. And normally what happens is that those adolescents are put into an adult ward, and that can open up a whole spectrum of other issues. So for us, it's really just prioritizing mental health. And in a time when there's so many different strategies and task teams for economic development, it's really important that we make sure that mental health also makes a special task team, that there is a suicide prevention strategy that is also followed during this time. And this is something where it's so important for mental health professionals, NGOs and governments to work together to really prioritize suicide during COVID. In South Africa specifically, we're reaching our peak or our first wave of the pandemic. And we can already see a huge increase in demand on psychological services because of the impact. And this will be longer lasting than COVID. And this is why it's so important to put in those task teams and those strategies in now so that we can deal with it in months to come.
Thanks. And I'd like to turn to Chris now and say, you know, from what Cassey said, does that chime with your experience of suicidality in the community during this pandemic?
Yeah, absolutely. There's a lot of facets to it, and getting help, and now with the video availability for counseling, we lack that human contact, which I think is essential in many cases. A lot of people not seeking help, not reaching out. And I think there's a particular problem amongst, at least here, the elderly, because I don't know how it is where others are. I can only speak for my own unique area, and I can't even speak for the entire US, but I've got family in senior living communities. They're not nursing homes, nothing else. They're simply apartment complexes for seniors, but in two of my family members, they've been not allowed visitors, can't get their car out of the garage and bring it back. You know, and they go, but they can't bring their car back in the garage, so they don't go anywhere. They're told they'll be quarantined if they leave, but yet if they don't leave, they're effectively quarantined the entire time. And other people wouldn't put up with that in an apartment, like non-senior. So I really worry about our seniors, and from a 911 perspective, emergency perspective, you know, we get a lot of calls that I'm convinced people are lonely. That's their chief complaint.
Right. So what we can't do is basically say what we need to do is to control this virus, and then mental health comes up as this other strand that we'll get to at some point. But from what Cassey said, from what you've said, Chris, it sounds as if this that suicide prevention has to be part of the the COVID-19 strategy really now and then preemptively, because we know that economic woe is already here. We know that more economic woe is on the way. We know that economic problems are associated with increased rates of self-harm and suicide. These are things which we can preempt if we act now.
Yeah, absolutely. And to add to that, we've increased, we've seen an 11.39% increase in fatal overdoses and a 16.56% increase in non-fatal overdoses. Now, that's not to say that they're all suicide attempts, but many of them likely are. So that's another facet too. And then that's not touching the domestic violence component. There's a lot more domestic violence between spouses. Child abuse cases are increasing. And then what I call mask rage, sometimes like a car rage. But in all these things just add into that perfect storm of suicidality, right?
Yeah, what you've described is really a good encapsulation of why suicide is such a difficult problem to tackle, because it is multifactorial. And that really brings me back to Michael and this issue of pesticides. Now, Michael, it's all very well to say that what you need is to make pesticides less lethal, but pesticides are the product of private companies, and pesticides are sold to consumers. And this is a system which surely is traditionally outside the purview of mental health services. So how can your recommendations actually be made a reality, and how can pesticide control really operate in order to reduce deaths by suicide?
There are many, many pesticides out there. There are people who argue we don't need pesticides. So there's the FAO, Food and Agriculture Organization, is very much moving towards an agroeconomy approach, just trying to minimize use of chemical pesticides for multiple reasons, for bees, for environment, for households, for occupational exposures. So we have a lot of pesticides out there, and the ones that cause most of the problems, that are causing most of the suicides worldwide, you could list in 3 or 4 hands. There are 15, 20, 30 compounds. If those were to go, self-harm would become much safer. So part of my public health approach has always been, can I make self-harm safe? Self-harm per se recognizes a bad situation, that's quite the right word. It's not something you want to encourage, but some people get relief from self-harm, can deal with their problems. But if you can make it safe, you can prevent suicide. So what we've always argued in the past is that many deaths from pesticide suicide are occurring with low intention poisoning acts, where people have got no intention to die at all, but are using self-poisoning to communicate, I'm hungry, I'm hurt, I'm angry, I'm doing this because of this, this, and this. But they grab the wrong bottle. And there's one simple story here that tells you this. So there was an older man in Sri Lanka who came in. He had long-term problems with alcohol. He had multiple crop failures. Who had gone to the pesticide shop and bought a pesticide bottle and was sold a low toxicity insecticide that really had no harm for humans because it was an insect-specific compound. He stood in front of his family and said, I'm going to die because of how you treated me. He drank the bottle, he fell to the floor and was rushed to hospital, where he remained completely healthy. He had wanted to die, but the pesticide wasn't toxic. Afterwards, he was able to get help from the health services to deal with his mood and with his alcoholism. So that crisis didn't become a suicide, but only because the pesticides are available. So if you can remove these highly hazardous pesticides from communities, you can clearly save lives. And policymakers, by help, can recognizing that pesticide regulation is effective, and actually the WHO has now shown highly cost-effective for suicide prevention. There needs to be collaboration. As you say, this is not a mental health issue. This is a big global how the community, the society uses pesticides. It involves agriculture, health, and environment ministries. And what's needed is what countries don't know at the moment is which pesticides are causing problems. People talk about pesticide suicides, but there's 1,000 pesticides out there, and only 15, 20, 30 are causing problems. So identifying those, using the FAO's guidelines of how to remove them, will actually result in far fewer people dying. Now, clearly, that's only one part of a suicide plan, which is about mental health, about socioeconomics, and about, I guess, mental health provision. But it is one key thing which very rapidly will make a huge difference. And that's why we talk about it being a low-hanging fruit.
Thanks. Now, again, to go with the complexity, we have a lot of questions. I'm afraid we'll only have time to get to 1 or 2 right now. But the one which has really caught my eye is from someone who's watching this webinar, and they're expressing the concern that knowing more about suicide and talking about it might be counterproductive, that the more information, the more talk there is about suicide, maybe the more likely it is that people will harm themselves or will attempt to die by suicide. Now, Murad, is that the case? Or is it a bit more complex than that? Is it not just about the amount of conversation there is, but maybe the type of conversation as well?
Yes, I agree. I think it is more complex than that, and it is also one of the myths that has been around suicide, that if you talk about it, you can actually make a person more likely to attempt to kill themselves. No, it isn't. But I think the discussion has to be balanced. Whereas you raise issues around suicide, risk and risk factors and so on, you also have to balance that by also talking about preventive factors. How can people get help? How can suicide not be the answer to people's problems? And that there are different avenues, different ways of how they can address the problem. So it has to be a more balanced approach. And I think we've got enough information now from research, from evidence, from lived experience of people. And what Michael is saying, that in the throes of a crisis, the intention may not be there, but the person reaches for a compound or a substance that is highly lethal. If you can somehow curtail that, intervene at that time, then perhaps so many people may not be dying from suicide.
Thank you. I'd like to just ask Cassey a sort of extension on that question, really. Do these sorts of worries about the effect of the way suicide is talked about, the way the media reports it, is that something which you cover in your work and which affects the way that you communicate what you do?
Absolutely. It's really important to control the narrative about how we're talking about suicide, and especially in South Africa, where we're talking about, these concepts around mental health that for a lot of the cultures isn't recognized. In South Africa, there is no Zulu word for depression. So talking about depression or suicide is often not understood in most cultures. So for us at SADAG, when we're talking about mental health and creating awareness in press and media, reaching people, we work very closely with press and media journalists on responsible reporting. So making sure how we're talking about suicide, where, when, is really important to us. It's a very sensitive conversation. It can be triggering to those who have lost loved ones to suicide and those that are feeling suicidal. But what we found is that the more we can talk about it and exactly, sharing those protective factors, how to get help, even empowering loved ones on how to access help for someone who's in crisis, is really important, and we see a direct result in the number of people reaching out. So for us, it's about having more of those conversations, getting used to having those conversations, and starting them earlier rather than later.
And if you're in the UK, or even if you're not, it's worth going to the Samaritans UK website and reading their guidelines for media reporting of suicide, which are just very, very useful guidelines. Now there's time for one more quick question, and this is an important topic, of course, which is alcohol restrictions as a method of preventing suicide. The person asking this question says the link between the two, alcohol and suicide, is an inextricable link. So I'd like to ask Chris, from your experience, what do you think about that link between alcohol and death by suicide and the possibility of alcohol restrictions as a means of suicide prevention?
Sure, that's an interesting question, and I'll quote one study, which I can't recall the author off the top of my head, but approximately 29% of people who die by suicide are positive for alcohol, but that doesn't mean that they're intoxicated. The statistic was positive for alcohol, right? And some people call it the lubricant to suicidality, and certainly we know that it decreases your inhibitions and increases your impulsiveness and that kind of a thing. But restricting alcohol, this is going to be the paramedic in me is going to be concerned, because I worry about DTs, delirium tremens, or alcohol withdrawal. And I know here in the U.S., liquor stores were designated as a necessary business. They were not shut down at certain points, and part of that reason is if we can have people in alcohol withdrawal, or which can be a delirium tremens, you can die of it, in seizures. So that concerns me a little bit. can you temper that with alcohol cessation programs? But to pull that off during a pandemic and isolation and by video and without support groups that perhaps would meet in person normally, it seems like a daunting thing to me. So I guess that's a qualified, I'm concerned about that, but I've just kind of played with the notion a bit here, but without a real nice, neat bow on it, I guess.
Yeah, well, that's the thing. I think that it's difficult to put a nice, neat bow on anything. I think that these things can be considered and they have to be thought about very carefully. The unintended consequences have to be thought about very carefully. And as we've been discussing all along, they've got to fit into the particular national economic cultural context. Now we are already a bit over time, so I'm going to move to a roundup question for all of the panelists. Now, those who've watched this before will know that I like the answers to this to be in Twitter style, 280 characters or less. Even 140 characters is great. So my question is very simple. It's what is the biggest priority right now in the midst of this pandemic in terms of suicide prevention? And I'd like to start with Murad.
So I feel the number one suicide prevention strategy amongst many that we have discussed is connectedness. So no one dies by suicide, or everyone who dies by suicide dies so in isolation. So I really feel connectedness, making connections, reaching out to people is the number one suicide prevention strategy. And I also feel the number one line of defense against suicide is our family, friends, and work colleagues. So if we learn the basics of communication, how to reach out and to make contact, I think we might be reaching people who have been contemplating self-harm.
Thank you. Cassey.
So difficult to fit in such a short Twitter, but I'll try. I think for us is, especially for developing countries, is making help accessible to whichever means possible, not just to elite groups who have access to internet or resources. It's making sure that everyone has access to help. And I think for us is we can do whatever we can on the ground to create awareness, shout loudly, advocate for people who need help. But we're needing to create a bigger village to make sure that we're making suicide a priority. And especially during COVID, is to make suicide prevention and mental health part of the strategy for COVID.
Thank you, Cassey. Chris.
I'm just going to have to agree with Murad. The social connection is the biggest thing that we could do. We're so tied up in, at least where I am, in talking about social distancing. But social distancing is bad. We need physical distancing, not social distancing. And I think, there was a study that I think Holt Lindstedt put out that showed that an adequate relationship with one other person, was more important for your longevity than quitting smoking or losing weight. Now, I'm not giving people permission to eat whatever they want or smoke like crazy, but that we're wired to be social critters. That is just so important. So yeah, I'm going to go with the social connection.
Thanks. And finally, Michael.
I am completely focused on pesticide poisoning, which I think is a small element. It's the low-hanging fruit of this. I'll defer to the other group. I'll give my Twitter characters to everybody else. I mean, I think those answers are really very nice answers. I can't improve.
Thanks. And I think that the overall message is that suicide clearly is a devastating experience for individuals who experience suicidality, for families. Indeed, it affects the care teams who look after these individuals. And it's very easy in these circumstances to feel helpless, but I hope that the audience for this webinar today has got the message that you're not helpless, that there's so much that can be done and that everyone can do something. So thank you very much to all our panelists for joining us. For those of you who are watching, please join us again next week. We've got a great webinar lined up on workplace mental health. There's one the week after on substance misuse. If you go to United for Global Mental Health's website, you can find all of the details there and register, and the notes and the recording from this session will be online as soon as we can put them there. If you'd like to tweet, again, our hashtag is COVID-19MH. So please do tweet us. Please do let us know any additional points you have. Unfortunately, we had to have a short discussion today. We could have gone on so much longer. But for now, I'd like to thank, again, everyone who's joined us, all of our panelists, and please join us again next time. But for now, goodbye.